So we're gonna start talking about neutropenic fever. That most of you guys already probably had patients with neutropenic fever. You do a lot of Sloan, you do also 9A, so you do oncology patients. So just very quickly, how do you define neutropenic fever? It's kind of intuitive. I'm sure all of you guys already know. Fever, and you need to have a patient that's neutropenic. So fever, so whatever is higher than 38 Celsius. And the definition of neutropenia, it's usually an ANC, an absolute neutrophil count of less than 1 or less than 1,000. However, we can identify neutropenia and kind of stratify it. You have neutropenia less than 1, also less than 1.5 can be considered very mild neutropenia. And then you have severe neutropenia if the ANC is less than 0.5, and profound when it's less than 0.1. So basically almost no neutrophils at all. So you will define neutropenic fever when you have one of these ANC values and a fever, or that the patient is coming with a fever and the ANC is still 1 or 1 point something, but you're expecting the ANC to go down in the next hours because maybe the patient is receiving chemotherapy. That's also considered neutropenic fever because you know that the patient will become neutropenic soon, okay? So that's pretty intuitive. Why do we consider it an emergency? So patients that are neutropenic, of course, are going to have a very suppressed immune system. So when they have an infection, bacterial, even from other sources, it can be really fulminant. The other issue is that since their immune system is not working, sometimes they only have a fever, but they don't have any other signs or symptoms. There's something wrong with their body. So that fever really tells you that the patient is really sick. It's important to have a timely treatment. Technically, you should start treatment within 60 minutes of that fever. And this is important because their immune system is not working. So their mortality can be really high. Up to 70% of these patients will die if we don't treat them correctly. And if we actually give them the right antibiotic quickly, so the mortality up to 4%. So it's very important that we identify these patients and that we treat these patients. Presentation, I don't even know if that's important because I mean it's intuitive, right? We have a fever, we have a neutropenic patient. That's it. So you just need these two criteria to have a neutropenic fever. And what are the risk factors? Do you guys know of any patient that might have a neutropenic fever? Any risk factors? You can type it in the chat or just unmute yourself. It's only us. I don't see Dr. and Giulia, so no one is watching us. What are risk factors to be neutropenic? Anything that you guys maybe have seen? So cancer, chemo, leukemia, chemotherapy. Perfect. So HIV. So it's not only patients that have cancer, also patients that can be immunosuppressed from other reasons. Perfect. Immunosuppression in general. And this talk, we're going to focus more about the oncological aspects, but some of these will also be important for patients that are immunocompromised for other reasons, as you guys are saying. So chemo is a big one, and usually you need the timing of the chemotherapy because that will suppress your bone marrow usually within 5 to 15 days from the last treatment. So it's important to know when the patient had chemotherapy because then you can expect them to become neutropenic. And then some patients are more at risk than others just because of the type of the chemotherapy that they're going to get. So usually higher risk for neutropenia is going to be patients with heme malignancies like leukemia, less lymphoma, but especially leukemia, but both of them. And then patients that are undergoing bone marrow transplant. And this is because this chemotherapy for liquid cancers, you really want to kill the bone marrow cells. That's your point. You really want to have neutropenia on those patients because those cells are the malignancy. So that's why these patients are at higher risk, and you need to really, assess them quickly, treat them quickly when you're slow, when you're in the hospital at West. Okay, so we start a case, and my disclaimer is that I created these cases thinking that you guys are the resident and not the intern. Because in a couple of months, you will be the intern. So I want you guys to think about what you would do if you were, a night flow or the medicine team on the resident the residents in your medicine team, and that you have to, create a plan for your patients. So I'm going to read it out loud. So let's say it's your ambulatory block. And for the prelims, let's say you're visiting an outpatient, clinic. So you're not doing inpatient. And I picked WFR just because that was my clinic. And if you have WFR, that patients are crazy. They're extremely sick. They're going to have 1,000 comorbidities. They will come with 10 different problems at the same time. And you never know what's happening with them. So it's 10 a.m. and your patient's not showing up. So you're assigned a walk-in, which happens all the time. So you spend hours pre-rounding and checking on your patients. And then there's something totally new coming up your way. You're like, okay, I have no idea what's happening here. Okay, so and she's asking to be evaluated because of fever and generalized weakness. She had a history of metastatic ovarian cancer that was diagnosed 3 months ago. She's on IV chemotherapy, and she also underwent surgery. She had cycle 2 of chemo 10 days ago, but unfortunately, her oncologist is out of town. So usually she calls her oncologist, but right now he's not reachable. So that's why she's coming to Ryan Center. In the afternoon, she became fatigued. This morning, she had a temperature of 39.1 Celsius, and she also has nausea and vomiting. The rest of the review system is negative. There's no other chronic medical problems, but she also tells you that last time that she had the first cycle of chemotherapy, her neutropenia was prolonged. In the temperature is 38.6, her blood pressure is 110/70, and her pulse is 112, so a little tachycardic, but regular. Her respiration is 20, and her pulse ox is 96% on room air. She's alert. She has no lymphadenopathy. Her skin is clean, no rash, no erythema, no tenderness around the subcutaneous venous access device where she gets her chemo. Lungs are clear and no heart murmurs. Abdomen is soft, non-tender, and your exam is normal. What is the best next step? I'm gonna pull up a poll, which is totally anonymous, but I want at least 50% of you guys to give it a try. So the options are prescribe oral ciprofloxacin and augmentin, prescribe oral cephalexin, send the patient to the ER for IV antibiotics, obtain blood work in the office, and then check also her neutropenia. Let me just pull up. Okay, what do you guys think? I don't know what you're answering, so just try. %. Any more people? Come on, guys. Again, Dr. Drill is not here. Okay. Okay. Okay, I'm gonna end. I'm gonna share with you guys. So most of you are right, are saying C. Some of you D and A. Let's see why the right answer is C. So first of all, there's a little bit of a hint that you can see in the stem. But before we go there, just want to show you. And this is something, let me see what. So technically, this is something the oncologist will do, but this is taken from EXA. This is something that the boards will ask you. So you're going to have an idea, even though you don't want to do chemo. So when you have febrile neutropenia, you need to stratify the patients very simply. You just need to know, is this patient low risk? Is this patient high risk? Okay. With low risk, that you are expecting the neutropenia to be short, will go away. And that's usually for oncology patients that have solid tumor or even lymphoma patients. Most of the times, their neutropenia is not going to be that long, that profound. So if the patient has a solid tumor like our patient, you might think, okay, low risk, outpatient. Second, they have to be stable. Of course, if they're immunologically unstable, like any patient, you would send them to the ED, but that's obvious, kind of. And then they don't have to have complications. And complications, for example, if a patient has neutropenic fever and they have new neurological symptoms, they have a lot of abdominal pain, which is new, they have diarrhea, those patients, you need a further workup. If there's nothing of these 3 points, then the next step is to see if they are able to tolerate oral intake. If they can, then you can treat them outpatient. If they cannot, then you need them to send it to the ED. On the other side, there's high-risk patients, which patients that you're expecting to have a profound neutropenia for a long time. So leukemia patients, patients that have bone marrow transplant, not any of those, but we'll see what happened in their case. Any patient that's hemodynamically unstable, that's obvious, we already know that. And then, as we were saying, any complication that makes us worry, new abdominal pain, skin rashes, hypoxia, all of this needs to go to the ED. So going back to our case, why do we need to send her? So option A and option B, it's oral antibiotics, which is not always wrong. But what's happening? She already told us that she has, sorry, but this is a little slow, that she has nausea and vomiting. So the stem is telling you, the patient is telling you, I'm vomiting. So you are worried that if you send her home with antibiotics, she's not going to absorb anything. So that's why A and B are wrong. What about C? So C is the right one, but what about D? You cannot just do it inpatient, like outpatient, and just send her home, because she told you another thing that's important. Even though she has ovarian cancer, so she has a solid tumor, she told you, you know, when I had my first cycle, the neutropenia was prolonged. So you're worried, if she's still neutropenic, what's going to happen to her? I cannot just send her home if her neutropenia is prolonged and she's vomiting. She needs to be assessed in the hospital. So that's why the correct answer was C in this specific case. But let's say she had no vomiting. Let's say she had no prolonged neutropenia. It would be totally safe to give her oral antibiotics. Okay, guys, let's go to the next step. Now is in the ED because you guys sent her from Ryan Center, like always happens. It's from WFR, you have EMS bringing patients to the ED, and she's getting her workup. Okay, so her CBC has an hemoglobin of 10, platelets are 40,000, leukocytes 600, and neutrophils are 15%. And that's something that I wanted to tell you. Let's say you don't have a differential. So when you have a CBC with diff, you will see the ANC because it will just tell you the absolute amount of neutrophils. You can calculate that, and you basically just take the white blood cells and you multiplicate them by the percent of neutrophils. Technically also the bands, if you have any bands, which is not frequent. So in this case, it will be 600 times 0.15, and you will know that this patient is neutropenic very, very quickly, okay? But that's usually how a board question will be like. They might not tell you the ANC, they might just show you the percent of neutrophils, for example. So also you have a normal creatinine and a normal BUN. They do a chest X-ray in the ED, and there's no opacity, no effusion. A is negative. They send 2 sets of blood cultures, and they start IV fluids. What is the most common source of infection in this patient? A, respiratory tract. B, GI tract. C, external device, such as the port that she has. And D, urinary tract system. Let me again pull up. Okay. What do you guys think, given what information we have so far? Okay, I'm gonna end the poll. I'm gonna show you. Okay, so most of you guys are saying B, and then also a little bit of everything else. So the correct answer is B, and I'm gonna tell you why. So first of all, if you do not know that, and you will learn now, times when you have neutropenic fever, the source is the GI tract. But let's say you didn't know that yet, okay? Why is in this case the GI tract? So going by one, respiratory tract less likely because she has no, URI symptoms, no cough, she's not hypoxic. Yeah, they'll say nausea, vomiting, absolutely. She also has nausea, vomiting, but sometimes that can be just from the chemo, from the cancer, so that's not 100%. It might be, let's say that she has actually like a gastroenteritis or something, but that might not be the only reason why, but absolutely. So her chest X-ray is negative, as Lenny is saying. So respiratory tract is less likely. And external device, that's all a very important point for these patients, they always have a port. They always have something. So even if they come all, dressed up with 1,000 things in the ED or wherever, you need to undress that port, you need to touch it. But we already examined her, and we are trusting the paperwork from your co-resident from WFR, and he's saying or she's saying that there's no erythema, no tenderness, nothing around the port. So less likely to system. Again, she has no UTI symptoms, and her urine are clean, even though we'll go there later, and sometimes that can be very tricky for neutropenic patients. So most likely, the best answer would be the GI tract. And as I was saying before, the most common source of infection for neutropenic fever is actually the GI tract, because it's always full of bacteria. These patients are neutropenic, so their immune system doesn't work very well. So you have translocation of these bacteria from the intestine to their blood. And this is why it's very important, as we were saying before, to have treatment for these patients very quickly. Because a lot of the infections from the intestine are gram-negative, and gram-negative can be extremely deadly. Don't know why you can't see. Okay, now you can see it. So you have a lot of enterobacteria, pseudomonas, which are gram-negative, and they are extremely deadly. So that's why you need to treat them very quickly, because most of the times that's the source of the infection. And then in the recent years, there's a lot of catheter-related infections, so a lot of gram-positive too. So you have, quag-negative staph, virulent streptococci. They also can cause a lot of bacteremia. That 40 or 50% of the time, you never know what's the cause of the fever. So everything will be negative forever, and you will just not know. So that's the issue. Why usually it's GI. Okay. So what's the workup? Very similar to any patient that's coming with fever. The only difference are some of the details that you have to be more aware of because of the history of these patients. So as we were saying before, you need to know what chemo they're taking, because there's a big difference from taking immunosuppressive therapy or like, for example, pembrolizumab versus having induction for leukemia. And that's not something you need to know, but the strength of this treatment is so different that the risk of neutropenia is different. So you need to have an idea of which treatment they're taking and the timing. As we said, the nadir for the neutropenia, so when the chemotherapy will actually kill the bone marrow cells, it's usually 5 to 15 days from the regimen that they more or less. So that you're expecting that patient to getting better, or if they're getting worse. So you need to know, like, where is the neutropenia going? Is this getting deeper and deeper and becoming very profound, or this is actually improving because the chemotherapy was 20 days ago. So that's why you need to know that. Infection. This is very important for neutropenic patients. You need to know if they had, recent infection, or what's the history of infections, why. Let's say that they tell you, 2 weeks ago I was in the hospital with a pneumonia, and then you go back in Epic and you see that they have a MRSA pneumonia. You already know that the patient might need vancomycin. Even if right now they don't have a pneumonia, you might be, more prone to just start that vancomycin in that specific patient. So you need to know which treatment they received, which infections they have. If they had any type of multi-drug resistant bacteria, you will start the treatment already. Even if it's big guns antibiotics, ID will be with you, because this is a neutropenic patient, different from the usual patients. That's why you need to know this specific information. And then recent antibiotic prophylaxis. So this is a talk for another time, but a lot of neutropenic patients might be already taking prophylaxis with antibiotics, antiviral, antifungal. So you need to have an idea about that, because, for example, if you're starting treatment and they're already taking a prophylaxis, you need to stop that because you're starting another antibiotic. So they cannot take 1,000 medications at the same time, especially if it's antibiotics. And physical exam, as you would do for any patients with fever, you need to check everything. We said before, they always have a port. They always have something where they're getting the chemo from. So undress them, check their skin, see if there's any tenderness, any erythema. That's important. And also the mouth. I don't know if a normal patient that comes with fever, I don't know how much we look at the mouth, but these people might have an ulcer, and that's the sole source of infection, and they may be extremely sick from that. That's why it's more important. Point that I think is important, no digital rectal exam. And this is something you have seen if you do leukemia at Sloan. Some patients have something called typhlitis, which is basically the infection of the cecum, so part of the intestine. And they can come with blood in the stool. They can come with hematochezia. They tell you, I've been bleeding from my stool. You do not do a DR in these patients. And this is because the rectal mucosa is so fragile that if you put a finger there, you can help the translocation. We were saying that a lot of these infections translocation of bacteria from the GI tract to the blood. So you'd never do that, even if they tell you that they have blood. It's basically the same. So you want to do your blood cultures and you do one from the port. That's also different from your usual ICU patients. You haven't placed, that's not an ICU line that you place in the ICU. And usually we don't take blood from there. This is something that they're coming with. They're coming with that port. So you need to see if that's growing anything. And they might want to have that removed as well. So usually cultures from the port as well. Culture, that's what I told you earlier. So a lot of patients, if they have a severe neutropenia, they might have clean urine even if they have a UTI. So the fact that there's no pyuria doesn't really help you all the time to rule out an infection. And if you go down a lot of the times, they will just send the culture together with the UA, which I don't know if it's the best practice, but just to know that sometimes the UA can be totally clean and they still might have an infection. Chest X-ray, another big thing. Technically, you should decide which patients get a chest X-ray. In reality, all of them will get a chest X-ray in the ED or somewhere else. But if you do an evaluation of the patient, chest X-ray should be done just if you're suspecting a pneumonia or if you really don't know what's happening to the patient. The rest of the workup, that's usually for patients that are not improving and you talk to ID, they usually will ask you to pan the patient. A lot of them will need sinus CT, which is not something we usually do for other patients, but they can have sinusitis that are actually fungal infections and they might be extremely severe. Okay, so that's your workup. Now let's go back to our patient. I don't know why there's a lag between my PowerPoint and what you guys see. So let's see when it pulls up. Okay, perfect. So now we have done the workup. 3 p.m. The start team will admit the patient to medicine, and you are the resident on the team. So you wanna go see the patient, you reevaluate her, and you're discussing the plan with your intern before the attending comes for PM round. How long is the best initial treatment for this patient? And if you don't remember, so she's female coming with this neutropenic fever. We saw that everything looks kind of normal in labs and chest X-ray. IV cefepime and vancomycin. B, ceftazidime and Cipro. C, IV piptazo, which is Tosin. D, IV piptazo and caspofungin. E, oral Bactrim. Let me pull up the poll again. Okay. Something, guys. What would you give to this patient? One. You guys are choosing a lot of different things. One more answers. Come on. And guys, feel free to stop, interrupt me, ask questions. I haven't said that before, but. Okay, so the majority is saying A, and another big chunk of you is saying C. So the correct answer is C. Okay, and we'll go over the reason why. Okay, so we'll go over that, but most of the times, as we said, the infection comes from the GI tract. It's a translocation of gram-negative bacteria, and most of the patients that die is because there's gram-negative bacteria, and that's really deadly. Priority number 1 is always to cover gram-negative and cover Pseudomonas, because Pseudomonas is also an infection that comes from the intestine. And So you always need something that covers Pseudomonas and has a good broad coverage. So you always go with piptazo or with cefepime. So this is your go-to. Technically also a carbapenem, but that's more advanced. Usually we don't do that in our hospital. So you need cefepime, you need piptazo. So see for sure why the others are not exactly correct right now. So cefepime, I think this is something we do a lot, but technically, as per IDSA, I'm not telling you guys, you should not add this at the beginning. You add vancomycin at the beginning on a neutropenic patient is either if you think that the patient has a pneumonia. So if that's, I don't know, chest x-ray or symptoms tell you this patient might have a pneumonia, so you need to have a patient as a skin or catheter related infection. So anything regarding the skin, again, you need to cover possible MRSA. Third option, the patient is really unstable. Severe sepsis, hemodynamic instability, you want to cover everything, you never know. All of the other options, you don't need vancomycin as a first choice. You just need either the cefepime or the piptazo. Not a good option because ceftazidime and cipro, you cover Pseudomonas, but you don't really cover a lot of gram-positive, so that's not a good option. D, piptazo and caspofungin. Usually you will add an antifungal when needed. Patients that are not improving, patients where you're expecting an infection from the fungus, but otherwise you don't just do it from the beginning if that's not the case. And option E, I mean, I think no one chose it and you guys are perfectly right. That's not really going to help on any front on this patient. So I guess, let me see if this works. So your antibiotic of choice is cefepime or piptazo because you need good coverage and especially cover Pseudomonas. So that's what you should start. You should not start cefepime bank, even though we do that a lot of the times. Then if you suspect that there's a GA source in terms, for example, a patient's diarrhea, a lot of abdominal pain, and so a lot of symptoms or you have colitis on the imaging, then usually you want to also cover the anaerobes very well. So if you're doing piptazo, that's enough. But usually we do cefepime in our house. You might add metronidazole, which is flagyl. Then, as we said before, vancomycin if there's lung source, skin, catheter, or hemodynamic instability of the patient. Patient is allergic to any cephalosporin penicillin, and then you cannot give piptazo, you cannot give, the cefepime. You do aztreonam and vancomycin, and the difference this time is that vancomycin, you're not adding this for MRSA. You're not adding for lung source or skin source. Aztreonam only covers gram-negative, so you need vanco to cover every gram-positive, so you cannot remove the vancomycin. And then daptomycin, usually we don't use a lot for MRSA because it's inactivated in the lungs. So unless it's an infection that is not in the lungs, you don't use daptomycin. Okay, sorry, again, there's a little bit of a lag here. Important things, source control, so try to remove catheters as early as possible. And then a few more tips. We'll consult ID if the patient is not improving. And of course, that's something that you don't need to know right now, but you will broaden the coverage. You will add your vancomycin, you will add your flagyl if the patient is to add antifungal. And usually if the patient keeps being symptomatic after 4 days of treatment, you will add candidate list coverage. On the other side, and this happens, if the patient is totally stable, symptoms are improving, but they keep having some fevers, rather the antibiotic coverage. It just takes more time for this patient to get better, so you don't need to add all of your big guns if the patient does not have symptoms anymore and if they're getting better. We were saying before, a lot of these patients will actually be already taking prophylaxis. So before you start your cefepime, stop whatever they're taking as an antibiotic prophylaxis. But if they are taking antiviral, antifungal, you do a good med rec and see if you're starting antibiotics, you stop their antibiotics. But if you're not starting antiviral and antifungal, you keep the one that they were taking already. It's the continuation of that diagram. So as we said, here we have our low risk and our high risk. Low risk patients, if they can take oral, they have outpatient treatment with cipro and augmentin. High risk patients or patients that cannot take oral will have IV. We already went over which antibiotics, why and when. Treatment duration, again, that's something that usually you discuss. It's just for you to have an idea when you're rounding. You know what infection they have. Let's say they have staph bacteremia. ID will tell you this patient needs 4 weeks, 6 weeks, 3 weeks of that treatment. So you just complete that treatment and you are monitoring the ANC, because when the ANC becomes higher than 500, so that means that's getting back to normal, you can stop the treatment. So this means that, let's say that the treatment is 2 weeks and you complete the 2 weeks, but the ANC is still 0.3, but you've seen that's getting better. You maybe do 3-4 days more of antibiotics, and when the ANC is 0.5, you stop them. If you have no idea what's happening to the patients, usually, if you know that they cover their neutropenia, you continue the antibiotics, even if you don't really know what you're treating, until the neutropenia gets better. Or if you're saying this patient is going to have neutropenia for weeks, they just had treatment for leukemia, this is not improving, you cannot give antibiotic forever. Usually ID will tell you, we think that 3 weeks of this treatment is enough. So you finish that treatment and then you start just the prophylaxis, because you cannot give antibiotics at those high doses forever. So in that case, you just do that and just hope that the patient will get better later. This is a question that I put here because it was from MaxUp. I thought it was a difficult question, but probably you guys will be better than me. So let's go over it. So you have a 26-year-old woman. She's hospitalized with a temperature of 38, 10 days after her first cycle of chemotherapy with R-CHOP for lymphoma. Other than fever, she has no symptoms of infection. On physical exam, her temperature is 38.6. The rest of the vital signs and physical exam are normal. Lab results show leukocyte count of 1100, 10% neutrophils, platelets of 144,000, hemoglobin of 11.2, blood and urine cultures are pending, and chest X-ray is negative. You already started empiric broad spectrum antibiotics. Which of the following is the most appropriate additional management? A, reduce the doses of cyclophosphamide and doxil, which is the treatment she's getting. Start GCSF now. C, start GCSF on day 2 over subsequent cycle of therapy. And D, start levofloxacin prophylaxis before next cycle. Let me just pull up. Okay. I actually was surprised to find this question on MaxUp, but I guess this is something that they will test. So that's the reason why I put it here. Okay. I need more people to answer. Just guess something. Okay, just for the interest of time, I'm gonna end the poll and share it. Okay, so most of you are saying B, and some of you are saying C and D, okay? So the correct answer here is actually C. So start GCSF on day 2 of their subsequent cycle, and let's see why. I think there's just a couple of things that you need to remember, which are gonna be enough for the thing, and in general for MaxUp. GCSF, I mean, you're just giving this to help the bone marrow produce more neutrophils, okay? And that's usually something that the oncologist gives on day 2 of the chemotherapy, or if the patient is receiving a transplant, on day 2 of that transplant, just to help their body produce more neutrophils and more cells, and so reduce the risk of infections. That, though, as a 2 possible way of prophylaxis: primary prophylaxis, secondary prophylaxis. Okay, let's go back to our case. So primary prophylaxis is someone that you know will have neutropenia for a long time. Which patient is that? You tell me, guys. We talked about it. What patient is the patient that you already know will have prolonged neutropenia? They're going to have profound neutropenia after the treatment. Liquid tumors, perfect. And most of the times it's leukemia more than lymphoma. Lymphoma is liquid, but it's also kind of solid, okay? Perfect. So all these patients, liquid tumors, bone marrow transplant, previous history, prolonged neutropenia. So this patient, you know that they will become very neutropenic. They're at higher risk of having neutropenic fever and die from it. So you do a primary prophylaxis. So on day 2 of their chemo, regardless of what they're getting, you give them GCSF. So you are working with your bone marrow so that they don't get neutropenic fever. Secondary prophylaxis. So this patient, she's technically young. She doesn't really have a leukemia. She's not going at bone marrow transplant. She has a lymphoma, even though that treatment is pretty strong. The oncologist say, no, I don't need to do primary prophylaxis on this patient. She has a neutropenic fever. So she has a risk of dying from this neutropenic fever. Okay, I want to do secondary prophylaxis. So next time that she's going for chemo, I already know that this patient might have a neutropenic fever again. So on day 2, I'm giving her GCSF so that she doesn't get neutropenic again and she doesn't die from neutropenic fever. You can do B, start now, but that doesn't really decrease the mortality of these patients. So that's why even if you do that, that's not the best answer, okay? So that's just the only thing that you need to remember from this. We have 2 types, Neupogen, short-acting, cheap, inpatient. Neulasta, very expensive, very long-acting. You just do it outpatient because it's expensive. In fact, bone pain, and you can treat with Claritin for that. This is the first part. So let's go quickly. And this is just a summary of what we said right now. Another case. We have a 59-year-old male with history of Crohn's disease, complicated by fistula, who's found unconscious at home. He was treated with sulfasalazine, glucocorticoids, and immunomodulatory therapies like methotrexate, azathioprine, and mercaptopurine. But recently, he started on infliximab through a central venous access device. He was intubated in the field and brought to the ED, where his vitals were stable, temperature 36, heart rate 95, blood pressure 150/83, and respiratory rate of 20. His physical exam was notable for erythema of the face and edema of the face and neck. That shows there's like a lag again between my computer and this computer. The AC saw the patient and they screened them in the ICU because they're intubated. They're coming to you to give you sign out because you are the resident on call in the CACU. And again, you're the resident, so you're gonna make the decision. You open the chart, take a look at the patient's CAT scan, here shown, and the ICU attending is about to come and discuss the case with you. You want to impress him because you're about to apply to Pomfret. So, and there's a lag again. So which one of this is the most likely diagnosis? A, anaphylactic reaction to infliximab. B, Vena Cava syndrome. C, interstitial lung disease as a complication of Crohn's. D, mediastinitis. E, spinal cord compression. And again, I'm gonna poll. Hi. People, come on. No one sees the answer. I mean, I don't know what you guys are thinking. Okay, so most of you got it right. I don't know if it's because we're talking about heme emergencies or because you saw the CAT scan, but so this patient most likely has superior vena cava syndrome. And I mean, they're coming with this respiratory failure, they're coming with the edema of the face and rash of the face and neck. So that's classical superior vena cava syndrome. Okay, so now, what is superior vena cava syndrome? I'm sure all of you know by now. It's basically all the symptoms and signs that you have when there's obstruction of the SVC, which can be partial, can be complete. And then obstruction can be, you know, from external factors, so something pushing on the SVC, something growing inside the SVC, so from the internal obstruction, or sometimes if there's a neoplasm on the right side, that can grow inside the SVC and kind of invade the wall of the SVC itself. And the problem is that the vessel, the SVC, is very thin walled. So it's a very thin walled, low pressure system, so that you can, and it's easily compressible, and it's all around all these structures like trachea, esophagus, aorta, so that can compress in many different ways the SVC. And this little man just shows that the SVC drains blood from a lot of stuff, from the head, here, from the upper extremities, from this area. So there's a lot of blood going there. So when that's obstructed, it's a huge issue. And what's the emergency? So even if SVC syndrome is severe or if it develops too quickly, patients can die from respiratory failure or also from brainstem herniation because there's going to be a lot of edema on the brain. So we had the patient. We are suspecting SVC syndrome. Now, what is the most likely cause of SVC syndrome in our patient? A, diagnosed non-small cell lung cancer. B, fibrosis mediastinitis. C, thrombosis. D, metastasis from unknown primary cancer. Again, I'm gonna launch a poll. What do you guys think, given the history, presentation, the CAT scan? What are you thinking? Some more answer, guys. You have to go to SimLab, I know. Just I'll share it. So most of you got it right. This patient is thrombosis. I think it's a difficult question. I know because I chose the CAT scan, so that's why I know what was shown in the CAT scan. And we can go back, but the CAT scan here is showing that there is a thrombus. Again, I just know it because I chose it, not because I'm very good at reading CAT scan. But here, if you look at the stem, you have a good hint, I'd say, because this patient has a central venous access. It's always a very high risk factor to get a thrombus and then get, SVC syndrome. Cancer, there can be benign reason for patients to have SVC syndrome. And I think that's what I wanted you guys to think about. Now, let's go back. So causes, 65% malignancy, so a lot of times it's cancer. Cancer can, as we said, compress from outside, invade the wall, can do a bit of everything. And most of the time it's going to be lung cancer, so non-small cell, small cell. If it grows in the apex, it's going to be, can give you pancreas tumor as well. And then lymphoma, metastases, very few cases you can have germ cells. Thymomas is much less, common as cancers. And if 65 is malignant, the rest has to be benign. And especially now, thrombosis is a very frequent cause of SVC syndrome. I just want you to think that it's not only a central venous, like a CCU. Patients that have defibrillators, pacemaker, all of those leads, they can cause SVC syndrome, especially within 15 months from their placement. So that's something to think of when you have the CCU and all those patients that have all these devices, they can be a source of SVC syndrome. And then other causes which were more likely in the past, but now still possible, it's syphilis, TB, very uncommon fibrosis mediastinitis from histo or other like hypertrophy of the thyroid. So clinical presentation really depends on how quickly the obstruction creates. And this is because basically when you're obstructing, as we said, all this blood from all this area cannot go anywhere. So you're gonna have all of this edema, and it takes around 2 weeks for our body to open all the collaterals so that the body will try to reroute the blood from the SVC to the adicus, to the mammary vein, to all of the other systems to try at least to send some of this blood to the heart. And I mean, the common signs and symptoms that we all know, we all remember, the edema of the face, of the neck, of the upper extremities, which gets worse when the patient lays down, if they bend forward, even if they elevate like this, the arms, that's gonna make it worse. It's gonna create more pressure, you're gonna have more edema. 60% or more of these patients are gonna have dyspnea, so some type of shortness of breath. And shortness of breath is not only because of the edema. So first of all, you have all these larynx and pharynx totally compressed by the fluid that's not going away, but also think that the blood is not going to the heart. So there's decreased preload. So there's shortness of breath, almost like a heart failure picture, like there's no blood going to the heart. And then you have cough, you can have dysphagia because of the edema of the esophagus, and all these collaterals that are gonna open that you can see on physical exam. However, you need to worry not when you just see the edema, but when you have these symptoms. So alarming symptoms are stridor, hoarseness. That means that the compression of the larynx is severe. This patient might die from respiratory failure. So if you hear a sound, and this happened once at night, and you hear that sound of a stridor, you always need to check here, and you need to call your AC. And also, all the types of neurological symptoms like headache, confusion, strokes, the patients might go into cerebral herniation, they might die because there's a lot of edema in the brain. So that's really, this is just to show you what it looks like. So the cyanosis of the face and all these collaterals of the thorax. It's actually not specific for SVC syndrome, very important. Anything in this area that's growing too much, it's going to compress the veins. That can be the thyroid, it can be a thymoma, it can be SVC syndrome. And that basically shows that if you're extending the arms, then you cause edema of the face and that becomes all red. But that's not specific, that's not diagnostic of anything. You really need to know. There's no consensus on how to grade the severity of the symptoms. This is taken from UpToDate, just to have an idea that, you know, the grade 0 to 2 is the usual dyspnea edema of the patient. When you go to 3, 4, 5, then the patient has a lot of symptoms that are alarming. And I think one symptom we don't really syncope, and the syncope is because what we said, there's no blood going to the heart. So when the patient syncopizes and you know that they have SVC syndrome, that's really alarming. This patient might cope. There's no blood going to the heart. That's something to consider as well. Okay. Another patient. So you're doing the night flow. It's 3 a.m. And the STAR team adds you to this epic chat because there's a new admission. They say that there is a 36-year-old woman coming with a 2-week history of gradually worsening dyspnea on exertion, partial swelling, sensation of head fullness. She has had fatigue, night sweat, 4.5 weight loss over the past 2 months. Her medical history is otherwise unremarkable. She takes no medications. Her vital signs are normal. Physical exam shows no respiratory distress, no stridor. She has facial and neck edema, and her face appears flushed. After clear, cardiac and abdominal exam are normal. We did portable chest X-ray that showed some questionable opacity of the upper to mid lung field. Otherwise, BBC, BMP are normal. We want to admit her for further evaluation of her dyspnea. So what imaging should you order at this point? A chest X-ray with PA and lateral views, since you only have a portable, a CT chest without IV contrast, a CT chest with IV contrast, or you don't need any further imaging. And launching a poll, what do you guys think? Let's think it's night flow. There's no one you can talk to. What are you doing? I guess there's no real wrong or right answer. We're just talking. And the poll, you guys agree. Perfect. So the right answer, even though again, there's no wrong answer, I think here, but besides D, you do need further imaging, but the best answer is C. So you will want to get a CT with contrast, and we are really cheating because we already know that we're talking about SVC syndrome, but let's think that you have no idea. This patient, why are we worried? She's young and she has weight loss, night sweats, she has maybe an opacity in the lungs. She does not really have any symptoms of pneumonia either. So that's also worrisome. Like, why does she have all these symptoms? So you really want to see what's in the chest X-ray. And the best way to see both the parenchyma and the vasculature is always to get a CT with contrast if you can. That said, if you get first a chest X-ray with PA and then you do another test, that's also fine. But you guys did great. Now, what's happening? So you ordered the CT chest with IV contrast, and it shows an 8.5 right mediastinal mass with compression of the SVC. There's no thrombosis, no lymphadenopathy, no lung masses. At this point, would you call an ICU screen? Launch this poll. You're the resident, it's night, what are you doing? There's some conflict, but now, okay. Okay, so most of you are saying yes. For me, this is 100% a trick question, okay? So there's no right and there's no wrong, and we will see why. So first of all, never wrong to call for help, especially when it's night, and SVC syndrome can be a big deal. And I put this, it was supposed to start. Let me see if it starts. Can you hear it, guys? Okay, I stopped it. But yeah, I love the Beatles and I just needed 1 second to catch up with my voice. But yeah, so when to call for help? I think it's never wrong. I think there's just some situations when you always need to call for help. In this specific situation, if you said no, it's okay. She's stable, she has no stridor, she has no confusion, she has nothing really alarming right now. She's not hypoxic, the vital signs are stable. So you can watch her and that will be fine. If you call the screen, it's also good. Like maybe she's not gonna get into the ICU at that moment, but the ICU will monitor her. SVC syndrome can be deadly. So I think trick question, you guys should assess the patient. So where you do not want to miss the screen is what we said before, alarming symptoms. So patients with stridor, always look for stridors. You need to send them to the ICU. Vital signs, what we were saying about syncope or hypotension. This is very, very tricky. The patient does not have enough blood going to the heart. You need a screen. And then confusion. So anything that relates to the neurological aspect of it. If there's anything abnormal, the patient might have edema of the brain. So this is when you don't want to miss it, but I think there's no wrong or right in that specific context. This is the last questions, guys. Otherwise, we just skip forward, don't remember anymore. But so we're talking about that patient again. So which of the following is the most appropriate next step in management at this point? Dexamethasone. B, mediastinoscopy. C, call IR to put a percutaneous intravascular stent placement. And D, call radio-oncology for urgent radiation therapy. Let me pull up. What do you guys think? What would you do? And in this case, at this point, what would you consult? Radio-oncology, IR, what are you doing? I want some more people, just 40%. Okay. So most of you are saying A, some of you are saying C, and some of you are saying B. This was a difficult question. Again, this is taken from Mexup. That I don't want to be mean. It's just something that at one point they will ask you. The right answer is B, and I will tell you why. Stop. So, one by one. A, that's something we always think with SVC syndrome, but it's mostly the wrong answer for multiple reasons. First of all, you as a resident cannot choose DEXA. Like technically you need, but that's all of these options. But as a resident, let's say that this is not a question, it's a real life. You need someone to tell you to start DEXA most of the time. This is not spinal cord compression, so they're different. Medicine will change wherever mass is there, will change this structure. So you don't have right now, this specific patient, we don't know what's happening. We do not have a diagnosis. If you give her dexamethasone, that mass will change. And once you try to biopsy that mass, you don't have a correct diagnosis. So you will never do dexamethasone for SVC syndrome unless you have a diagnosis for that. That's why A is wrong. C, can be right, but ask IR to put a stent whenever the patient has so many symptoms that you are worried for that patient. So if she has alarming symptoms like the confusion, the headache, the stridor, then that's the best answer because they will put a stent that will not affect any tissue, so it will not change the results of your biopsy, and quickly the patient will feel better. But right now, she has none of these symptoms. She's 100% stable, so you do not need to do that at night at 3 a.m. And D, radiation therapy is the same as DEXA, will change the tissue. So if you do not have a diagnosis, you don't do radiation therapy. So it's something that you can do only when you know what that is. Also because dexamethasone will reduce inflammation all the time. So regardless of what's causing it, some of the inflammation with the steroids will go away. Radiation therapy will just be useful if that tissue will respond to the radiation therapy. So you need to know what's that. So otherwise, that's not going to be useful. So right now, the correct answer is B, because she's stable and you have the time the next morning to do a biopsy. Okay, so that's why the correct answer of that question was B. Now, let's go quickly. I think we're almost there. A lot of the patients with SVC syndrome do not require emergency intervention. Most of the times you have the chance to call your services and think about the best way to diagnose their SVC syndrome. So the workup, I mean, you're going to ask the questions of what's happening, how long they had symptoms, if they had a defibrillator or anything placed that can cause thrombosis. We already said that CT chest with IV contrast, the best test. And the ultrasound, it's only useful if you think that they have a thrombus. They will not see a mass with the ultrasound, so that's the only reason why you order it. Sonography is gold standard, but now you just do it if you're putting a stent. That's IR that will do that for a stent. For diagnosis, most of the times you just do a CT chest with contrast. And biopsy is needed if you do not know what's the diagnosis, if there's a mass. Of course, if the patient has a lymph node or something closer, you will do that biopsy, but otherwise you will do a mediastinoscopy and we'll go there and take a sample. Management, I just want to go quickly over this. It's not something you will ever decide. There's no one answer. Depends on what's causing the SVC syndrome. You always need to talk to 1,000 people, boom, radio, like, and they will decide what to do basically. But the only thing I wanted to stress out, it's an emergency. So even if it happens at night, and maybe you do not need an AC screen, but page oncology, like they need to know, they need to see this patient right away or in the morning, depending. They can help you triage the patient. It's not really useful. Technically, you can elevate the patient head to help drain out the fluid, and you should not overhydrate them. Don't give them 5 liters of fluid. It's gonna get worse for all the congestion they already have. And then again, this is not something you really need to know, but in general, depending on how severe the symptoms are, if it's grade 3 or 4, if the patient, this means the patient has stridor, confusion, syncope. This is, asking you stabilize the patient, you intubate the patient. While grade 1 or 2 means that the patient has the classical dyspnea, edema, and then we do what we just, depending on what we're thinking, we're going to decide. If we know that this patient has cancer, the oncologist will probably give them treatment. We know that there's a catheter placed there and that's just a thrombus, you will have to remove it and so on. So you just have the time to decide what's the best treatment. And this just explains quickly what these are. So the stent placement, the option C of that question, as we said, is the fastest way to have symptom relief. So the only situation when you call IR is that the patient has stridor, we need to have her feel better. And we do not know what's causing the syndrome. So you call IR, they put a stent. And the stent does not compromise your biopsy, so that's why it's a good option. Steroids, we already discussed that. You never do that if you do not know what's causing the SVC syndrome. And usually you just do that for some types of tumors, but that's not something we care about. Radiotherapy, same as steroids. You just do it after you have a diagnosis, otherwise it will mess up your tissues. Chemo, absolutely not something you need to know. If it's a thrombus, and it's because there's something, you need to remove that something. Even if it's a pacemaker, that depends. Sometimes they will just give thrombolysis, but sometimes even if it's a pacemaker, they might have to exchange that. Of course, that's not something we decide. But the general idea is that you remove the catheter, you give anticoagulation for a period of time. Sometimes you do also thrombolysis. It was very long, but do you guys have any questions, comments? Otherwise, I'll just give you a break before afternoon report, and thank you for staying with me.